Hi everyone, and welcome to Anesthesia Coffee Break. And hey Archie, we're going to start with the renal physiology now, aren't we?
Yeah, renal physiology. I think one of the other core topics that can be a little bit confusing. So I think it's great to start talking about it in little chunks.
Yeah, beautiful, and so relevant to anesthesia in kind of a lower key level because it's plugging away there. It's working. You'll have patients with renal failure. You'll understand why. You'll think about medications you can and can't use, and we'll also kind of touch on over these next few episodes about just the difficulties as well. Like when you look at urine output and acute renal failure, the fact that even though we'll learn all of this really cool stuff about kidneys, at the end of the day, it is just hard to manage and maintain kidney function. And our physician colleagues are amazing at doing that kind of work. So let's get started. So you've done a lot of just great work here because essentially you've gone through each of the syllabus points, and so I'll ask you questions like before about the syllabus points, and then and we'll just riff on just the important detail and try summarizing it as well to keep this easy to digest from a podcast listening and a YouTube point of view. Great. So the first learning point here is 1.61, outline the functional anatomy of the nephron. So maybe start with kidney anatomy. So tell me, Archie, about kidney anatomy.
Yeah, exactly. I think to contextualize the nephron, we need to understand the kidney first. So going through a few points about the kidney. The kidneys are paired retroperitoneal organs, and they play a really crucial balance in sort of a lot of the homeostatic mechanisms that play into our body. The right kidney is related to the liver, duodenum, ascending colon, the small intestine, and the left kidney is related to the spleen, stomach, pancreas, and the descending colon. Importantly, though, both the kidneys have an adrenal gland that's sitting on top of them, and we'll talk about why that adrenal gland is really important after, but you've got to know that they've got adrenal glands on top. The kidneys receive afferent innervation through splanchnic nerves, particularly around the T12 area, and have efferent innervations through the sympathetic fibers, again, of the lower thoracic sympathetic nerves. So these can directly activate the beta-1 receptors of the juxtamedullary cells, and we'll talk about why that's important later. But just remember, it's the sympathetic fibers, lower thoracic sympathetic nerves, B1 activation of the juxtamedullary cells. So clinically speaking, when you've got a renal transplant that's performed, the graft is obviously disconnected from those sympathetic fibers, which means that the recipient is actually no longer able to directly coordinate their activation of the juxtamedullary cells and in turn their renin-angiotensin-aldosterone system through their own sympathetic nerve. So that's a clinical tidbit that's important from a renal transplant point of view.
Yeah, great. And so this is one of those, I guess it could be a basic question or a first question in a Viva or in the short answer section. And just remember, everything that Archie probably said there, I think people know. Sometimes in a short answer question, you just got to have a framework for including information you would otherwise not think of including. So you can do a number of approaches. Like clinically, I often think of who, what, when, where, why, how, and just try to fill gaps in there. So, make an introduction to what this kidney is, maybe what it does, what it does, where, like everyone kind of knows where the kidneys are. So you could make a statement about retroperitoneal and what it's related to without having to memorize anything except knowing your medical school knowledge. And then definitely blood supply and innervations are useful to say. And the key here is sometimes we just don't know the blood supply, except for things like the diaphragm, where we always remember see 3, 4, 5 keys of diaphragm alive. Other organs, pretty much whatever nerves are running nearby will be the efferent and afferent supply. So, the fact that the kidneys are in the lower thoracic area, you mentioned afferent, T12 splanchnic nerves, sympathetic fibers are lower thoracic. So saying general terms like that is still very useful. And one of the other questions, so this will be what are some functions of the kidney? And this is a common question because the kidney has just so many varied functions. Give it to us.
Yeah, so there have been past questions that relate to exactly this question. So what are some of the functions of kidney? In terms of mnemonics, I've sort of broken it down into a mnemonic of waterbed. So W for water balance, A for acid-base balance, which is really important, and kidney play a huge part in that. Toxin clearance for T, electrolyte balance for E, renin-angiotensin-aldosterone system. So we talked about that, the RAS, and that's R. B for blood pressure regulation, E for erythropoiesis and release of erythropoiesin, and D for vitamin D activation. So that gives you an outline of exactly what are some of the functions of the kidney.
Beautiful. And just to give the catch that R and B are kind of in the same area, but hey, it helps make a mnemonic, and it's one that actually spells out a word that makes sense. So water, bed, water balance, acid-base balance, toxin clearance, electrolyte balance, renin-angiotensin aldosterone system, blood pressure regulation, erythropoiesis, and vitamin D, D for dog activation. Great. So let's get into some detail. What is, again, this is a common question for any organ. So I like to think of not just thinking of the kidney, but cross-referencing this. So we'll do a bit of this. What's the functional unit of the kidney? And this will be similar to thinking the functional unit of the liver as a lobule, or the functional unit of the lung as an acinus. So what is the functional unit of the kidney?
Functional unit of the kidney is the nephron. So nephron is the functional unit of the kidney.
Excellent. Yeah, tell us about the nephron.
Okay, so I guess talking about nephrons, just going back to the kidney, it's important to know that the kidney is actually divided into different layers. So firstly, there's the primary outside of the kidney, which is the cortex, and then you've got the medulla. So the cortex is the bit that's closest to the kidney capsule or the renal capsule, and it's further subdivided into a lot of other divisions, which you can sort of look up yourself, but it contains most functional areas of the nephron. So starting from the start, you've got your glomeruli, then moving into your PCT or your proximal convoluted tubule. You've also got the macula densa and the renin secreting the juxtamedullary cells, part of the juxtaglomerular apparatus that's around this area as well.
So the juxtaglomerular cells?
Yep. Yes, exactly. The distal convoluted tubule, your connecting tubule, and the initial part of the collecting duct, which then sort of dips down further. But the initial part of the collecting duct is in the cortex. And then you've obviously got the blood supply. So you've got your interlobular arteries, and then you've got your afferent and your efferent arterioles as well. Talking about the medulla, so the medulla is the rest of the area, right? So it's divided again into inner and outer medulla. Why this is important is because your nephrons are two different types of nephrons. You've got your cortical nephrons, which have short loops of Henle, which only sort of extend within the outer medulla area. Then you've got your juxtamedullary nephrons, which are sort of sits around 15%. They've got really long loops of Henle, and they dip down into your inner medulla. The inner medulla is a really high concentration of solutes, and it helps producing that concentrated urine. So that's why the juxtamedullary nephrons, which dip into the inner medulla, are really important for our water regulation, concentration of urine, because of that high osmolarity that's present inside.
Yeah, beautiful. And, it's probably worth, just for YouTube viewers, I've got this great picture from, Netters, that you put up here, which is great. And that it kind of shows you a really good, I guess a pictorial representation. You've got the normal cortical nephrons, and then the juxtamedullary nephrons here. And these are they're obviously the ones that, this length of this long loop of Henle is what allows you to have an immensely concentrated urine, and that's only 15%. So we've got far less of these than, say, some desert animals, and they often quote the desert rat as having extremely long loops of Henle. I imagine that they'd have lots of these nephrons as well. So just pause the video, have a look at that. Now, when you're drawing this, so in your exams, always learn how to draw something really quickly. So being able to just do a little squiggle for proximal convoluted tubule, and then a long loop of Henle with a thick descending, and then descending limb, descending limb, thin ascending and thick ascending, and then proximal convoluted tubule and cortical ducts in a very schematic way. It's just a very useful thing. So imagine all the ways that you might need to do that. You might need to do that for the locations of drug action. You might need to do that for talking about different solute absorption, like bicarb, sodium, potassium, whatever else, or just talking about concentration of urine. So just know how to draw that in a fast and schematic way. Okay, let's talk then. That's great. That's a great summary of the nephron. What is really relevant, but what is the blood flow of the kidney?
Yeah, yeah. So there's a number that's been quoted around, which says that there's about 1.2 liters per minute of renal blood flow. Which roughly equates to sort of around a quarter of our cardiac output. So as you can imagine, that's very high. That's a really high demand, right? But interestingly, unlike other organs, our blood flow doesn't actually depend on how much work the kidneys do, but how much work the kidneys need to do. So let that sink in your head. Because of the metabolism and the clearance and the urine concentration that's required, that's why that statement is factual. So there's 1.2 liters per minute of renal blood flow, and there's approximately about 600 mils per minute of renal plasma flow. So because of the large blood flow, it allows for a large amount of filtrate, or the glomerular filtrate, which is also quoted to be around sort of 180 liters a day.
Yeah, great. And so I want you now to, everyone listening to, what's really useful is to make a table of all the high blood flow organs in the body. So you'll learn these from a total blood flow point of view, a percentage of cardiac output point of view, and also per 100 grams point of view. So some of these organs that you'll have to learn. And there is look for a table in Lang Physiology, I believe it is. And that's just got a great summary of this kind of organ blood flow. And the ones you think about is all the things that require some kind of detoxification or filtration, which is liver and kidneys, just need a huge amount of blood flow. And other interesting organs, obviously the lung has the total cardiac output because that is all part of oxygen and gas exchange, and the brain as well. But then the adrenals and the carotid bodies are kind of those random little organs that require so much blood flow, especially the carotid bodies have the most blood flow per 100 grams, simply, and it's such a big part of respiration and the drivers to breathe as well. So really important to use this knowledge and then cross-reference it across all the different other similar organs or similar blood flow organs. Cool.
Yeah, exactly. So continuing on with the blood flow, the blood flow uniquely is supplied by a renal vein, which then has two separate capillary networks within the nephron, or within the renal functional area.
Renal artery, yep. Renal artery. Yep.
Renal artery, which then leads to a high pressure glomerular network, which is what you think of at the glomeruli, which forms the glomerular tuft. So you get the afferent artery, then you've got the glomerular capillary, and then you've got the efferent artery. So that's a high pressure glomerular network. But then it also has a low pressure peritubular network, which we'll talk about a bit later, and it forms the vasa recta, or it forms the blood vessels into the medullary nephrons, or medullary loops of Henle that we've talked about, forming the countercurrent exchange. So there's two separate capillary networks, and one's a high pressure, one's a low pressure. So moving on to sort of talking a little bit, sort of traveling through the arterial to the venous system. I myself hate lists, but this is an important list because it does come up, time and time again about what the blood supply is in terms of renal blood flow. So you've got your normal renal artery that comes off the aorta, which then goes on to your segmental arteries, which are really large end arteries. It then goes on to your interlobar arteries, supplying the renal tissue between the cortex and the medulla. The arcuate arteries, which then run like arc-like courses between those areas. Then you've got your cortical radial arteries, moving on to your afferent arterioles, to your glomerular capillaries, to your efferent arterioles. So afferent, glomerular capillaries, and efferent arterioles, that's your big area where almost all the filtration happens. Leah, you've got a photo there.
Yeah, so just check out. I mean, this is just from Britannica Online, just to help you guys orientate it if you're watching the YouTube video. But yeah, lists like this are probably not super useful unless you can see. But yeah, so what are the major important parts of this arterial and vascular network from your point of view?
I think you need to absolutely know the afferent arterioles, the glomerular capillaries, the efferent arterioles, because that's where your 90% of your marks are. And then you need to know your peritubular capillaries, which are next, forming that vasorector. So that's the big areas, I think.
Yeah, fantastic. And I guess what's really interesting then, these are end arteries, like there's very little collateral blood supply. So if someone has any kind of renal artery stenosis or is a vasculopath, they're at high risk of any kind of poor renal perfusion, therefore renal ischemia and acute renal failure in that perioperative period. So I think that's really important. And we'll go on to talk about you've got these different arterial networks, but you've got these vasorecta, which unlike most other arteries, they're just these just beds of very slow flow vessels that are just there to preserve the gradient. But I think we're going to go into that. So this is a highly pressure dependent organ. And what you'll find is, in the context of poor urine output, which is a common problem in major surgery, elderly patients, vasculopaths, poor urine output periop, the way we don't know a great link between urine output and renal issues, even though that's how it's mainly defined, but there's a lot that's not known. If you have a patient who's otherwise you feel they're urolemic and they still have a poor urine output, the way you can increase urine output is by increasing the MAP, which is kind of not what you see on the wards because we don't have the ability to just run NORAD for everyone. But once you fill them, once you've addressed all the other causes, the best thing to do is get that HG referral, chuck some, put a central line and get some noradrenaline, and bring up that MAP, because that's what will actually increase blood pressure. So this is a highly pressure dependent organ.
Yeah. Perfect. So that's sort of the relevant sort of blood flow anatomy. Continuing on from the nephron. So remember, nephron is the functional unit of the kidney. Each kidney has sort of millions and millions of different kinds of nephrons, but importantly, once destroyed, they can't regenerate. So you've only got a limited amount of nephrons in your body. So look after them really well. Cool. So then moving on to sort of that renal corpuscle area, which has the glomerulus. So the glomerulus contains these leaky capillaries. So from med school, we remember that these leaky capillaries or fenestrated capillaries between the afferent and efferent arterioles is how filtrate gets through. Around that area, you've also got the Bowman's capsule. So you've got your tuft of your glomerulus, which sits around a C-like area, which is the Bowman's capsule. That is responsible for the filtration and forming that ultrafiltrate. It's got a basement membrane. It's also got glycocalyces, and you've got a thin basement membrane as well as a visceral layer of the Bowman's capsule, which contains these podocytes. So these podocytes have these foot-like processes which allow for that, filtration barrier, because we don't want everything to come through. We just want some things to come through, which are really important to us. So that's what that area looks like, that glomerular area of the renal corpuscle. Once you get through there, so this allows for filtration, and the basement membrane has those fenestrations as well. And there's a size barrier that resists things getting through which are too big. So above 7,000 Daltons, it starts to resist things coming through. So under 7,000 Daltons, whatever can be filtrated, that's fine, it comes across. Between 7,000 and 70,000, it's got a decreasing filtration as the size gets bigger. So as you can imagine, 7,000 is going to be a lot easier to filter than a 70,000 Dalton molecule. So 7 to 70,000, and then 70,000 plus is just not filtered. So that's the size barrier. But it's also got a charged barrier, because a lot of these barriers are negatively charged. So it's got a charge barrier, which then repulses negatively charged molecules. So particularly things like albumin is what we care about in this area.
Fantastic. So we've got this structure here, the glomerulus, and the most important part of that is the fact that this is a filtration machine, and there's just millions of these in your kidneys. And as you mentioned before, there's a whole formula for this, but a lot of this is the fact that you have a size problem or size barrier and a charge barrier. And this is a massive part of it. What is that equation? Because this GFR equation is something we definitely have to know
Yeah, exactly. So the GFR equation, it's a balance of, so if you think about it, and I'd really encourage everyone to have a renal corpuscle in front of them, because this will really allow them to visualize exactly what we're talking about. It's a balance between the hydrostatic pressure and the oncotic pressure between the arterioles, so the afferent, efferent, and the glomerular capillary, and the Bowman's capsule. So it really, really vital interplay between those two. So it's governed by Starling forces. So the equation that we need to know is exactly what Lahiri's got up there, which is K. It's a filtration coefficient. And as you can see, it incorporates sort of the surface area and the conductivity, the hydraulic conductivity up there. Because of the glomerulus having these areas where, or fenestrations which allow things to go through, it's relatively high. But it can be altered, especially when angiotensin starts to act on your mesangial cells, which reduce your surface area. It then reduces your filtration coefficient. So that's your K, which is your filtration coefficient.
Fantastic.
Which is then multiplied by, in brackets, PC, which is your capillary hydrostatic pressure. So if you think about it, the capillary hydrostatic pressure wants you, or encourages, or wants to push things in to become filtrate. So that's why that capillary hydrostatic pressure is really important. But then that's opposed by the hydrostatic pressure of the Bowman's capsule. So if you think about it, it's the opposite effect within the Bowman's capsule. So that's why your first bit is your capillary hydrostatic pressure minus your Bowman's capillary hydrostatic pressure. Minus, you've got this sigma coefficient. So it's a reflection coefficient. So it basically means how leaky things can be. It's a range from 0 to 1, where 1 being that it's complete, whereas 0 means, things can go through quite easily. So that sigma reflection coefficient times by your capillary oncotic pressure, which wants to prevent filtration going through, minus your Bowman's capsule oncotic pressure, which actually encourages your filtrate to come through. So that's the equation, K multiplied by, in brackets, PC, or the capillary hydrostatic pressure, minus your Bowman's capsule hydrostatic pressure, minus your reflection coefficient times by your capillary oncotic pressure, minus your Bowman's capsule oncotic pressure. So really important to know that, because then you can really talk about the different factors that can affect this filtration.
Yeah, and often, just like there's a few formulas that come up time and time again in your whole primary exam journey, your fixed law of diffusion and Hug and Purcell equation. And if you imagine getting a question in about filtration, first of all, if you've just got that as one of your first lines, that this is the equation for GFR, for glomerular filtration rate, and you have an idea of these definitions, now we can manipulate it, like literally thinking that this is a balance of a coefficient multiplied by hydrostatic pressures and opposed by oncotic pressures. Hydrostatic pressures minus oncotic pressures. And then you can simply go, oh, well, if the capillary pressure is high blood pressure, you get more. If the Bowman's capsule pressure is high, say some kind of urinary obstruction, great, that's going to decrease it. If your oncotic pressure is really high on your in capillary, great, that's going to oppose it. How about if there's lots of protein for some reason in your Bowman's capsule, in your urine, then that's going to promote it. So you can just manipulate each of these values to get a reasonable answer. Good.
Yeah, exactly. I think the Starling force, it's a nice little formula. Yeah.
Beautiful.
So once you've got your ultrafiltrate, I think it's important just to sort of talk through the different pathways that it goes through. So we'll go through this briefly because we'll touch on these areas a little bit later. So firstly, initially, you've got your Bowman's capsule, you've got your filtrate that's captured within that area, then leads to your proximal convoluted tubule. The PCT, or the proximal convoluted tubule, is so important because it's responsible for so much of the reabsorption that happens. So things that are expensive to the body, so things like water, salts, glucose, it really wants to hold in. So it has a lot of mechanisms to reabsorbed a lot of those things. The other one that I haven't mentioned is also it reabsorbs about 50% worth of urea as well, and we'll chat about that later. But remember, 50% is sort of reabsorbed around the PCT. Once we've got that, we go into the loop of Henle. So most people might remember loop of Henle has two areas. You've got the descending limb and the ascending limb. The descending limb is highly permeable to water. So this is where we lose a lot of our water from the tubule into your interstitium and therefore into your blood system. Then you've got your ascending limb, which is impermeable to water, but contains so many of these channels that pump out salts into that medullary interstitium, which is one of the reasons why it makes it so salty in that area. So loop of Henle is a really important part of your nephron.
And I find that lots of people forget which side is which. And the way I think of it is your loop is the concentrating part of your nephron. And so if tubular fluid is heading down into the medulla, then water has to leave that tubule to make that loop of Henle concentrated. So it's going in one direction, you're losing water into the interstitium, and that's what makes the tubule concentrate. So that's why the descending limb is highly permeable to water. Cool.
Yeah.
The rest of it, the distal convoluted tubule.
Yep. So the DCT, the distal convoluted tubule, again, it's like a surrogate cousin of the PCT, where it's also responsible for reabsorption of more ions, but it's not obviously as powerful because most of things have already been reabsorbed. The distal part of the DCT, though, is an interesting area where it passes directly between the afferent and the efferent arteriole. So it kind of loops back around and sits between the afferent and efferent arterioles, where you've got really specialized cells in the walls of these tubules, closest to the Bowman's capsule, and they're called macula densa. So the macula densa, we'll talk about the autoregulation bit in a little bit, but that's why it's really important. So have a graphic in your head, or have a look at some of the graphics on Google, and you'll see that this DCT, or the end part of the DCT, actually wraps around and sits within that afferent and efferent arterioles, leading to that cool juxtaglomerular apparatus that it forms, and within that is the macula densa. And finally, after that, you've got your collecting duct. So again, more reabsorption happens, particularly of water, which is guided through aldosterone and ADH. There's also urea reabsorption that can happen in the distal collecting ducts, and we'll chat about that later as well. But that's the pathway of your, tubular fluid that goes through the nephron.
Beautiful. So your mission today, as I mentioned before, is to draw this structure, draw a schematic glomerulus with the Bowman capsule, squiggle, which is proximal convoluted tubule, the descending limb, the thin ascending, the thick ascending, the distal convoluted tubule, finally the collecting duct. And another thing, where do hormones act? So hormones will act at various sites as well, which kind of gives you a complete picture in a quick anatomical way. So tell us then about this juxtaglomerular apparatus. And the first challenge is actually saying that. So just make sure you pronounce, everyone, in your exam, pronounce each part of this, because it's not too bad when you just slow down.
Yeah, exactly.
We'll call it the JGA, why not?
But please mention what the JGA is before you just go on and say JGA. But it is the juxtaglomerular apparatus. So it, again, refers to the region where the distal convoluted tubule passes between the afferent and the efferent arterioles, and where the macula densa is located. So breaking this word down, juxta means next to or adjacent to, and glomerular is obviously your glomerulus. So in common sense, juxtaglomerular, next to the glomerulus. Then you've got your the JGA is important because it plays a part in your tubular glomerular feedback. This is to keep the EGFR stable and the blood volume, as well as the sodium levels within your blood, within the homeostatic levels. So the juxtaglomerular apparatus contains three distinct cells that we need to know about. Firstly, you've got your macula densa. So these cells, the specialized macula densa cells, sense flow, particularly of sort of the electrolytes that flow through there. But more importantly, the sodium concentration. So if you need to get something out of this, macular denser cells sense sodium concentration. That's what's really important. If your sodium concentration is low, it recognizes this, it puts in place autoregulatory things, triggers the release of renin, and then therefore it will increase your sodium through aldosterone and your RAS system. But macular denser cells, sodium concentration. That's what you got to remember. Your mesangial cells are other types of cells that also sit in the JGA. They're kind of, I think of them as like structural sort of sponges, structural sponge-like cells. So they can constrict and then they can dilate, and this can influence your EGFR by reduction in your surface area, particularly done through angiotensin II, which will have a direct effect on your arterial tone, which can lead to a variability in your EGFR. And lastly, you've got your juxtaglomerular cells. So juxtaglomerular cells are also known as granular cells. So you might think granular cells, what do they contain? They contain granules of renin. Renin is a really important enzyme as part of your renal physiology. And again, we'll touch on that in the coming episodes. But renin in turn will then lead to increasing in your blood pressure through your angiotensin II, as well as release of aldosterone, which will increase your sodium absorption and your potassium excretion. So these JG cells, or the juxtaglomerular cells, can be triggered through, one, your sympathetic tone. So if you've got low blood pressure, your sympathetic output is high, you're directly triggering these through your beta-1 receptors. This can release renin. They also have their own little baroreceptors that can help trigger them to say that, hey, the blood pressure is a little bit low, time to release a bit of renin, boost this up. And finally, the macular denser cells can also then trigger these juxtaglomerular cells to release the renin. So these are kind of like our action figures that are in this GGA, and they can influence your blood pressure and your sodium concentration quite a lot. So that's why your juxtaglomerular apparatus is so important. About keeping the EGFR stable, but also the blood volume and your sodium concentration.
Fantastic. Actually, that's a great summary. And I think that's pretty much the first syllabus point done. I'll just recap it. And, if you look at this, each part is a question. I find often studying by answering questions is another way of studying. Like, instead of just thinking, tell me about kidney anatomy. Like, to answer that question, what are the important aspects of kidney anatomy? Or, tell me, what is the nephron? That helps me formulate an answer to a question, whether it's a Viva question or short answer question. So we've gone through kidney anatomy. We've talked about the functions and waterbed as the mnemonic for that. We talked about the anatomy of the nephron, which is the functional unit of the kidney, the cortex and the medulla, being able to draw that structure, the nephron structure in a simple way. We've talked about blood flow to the kidney and why it's so interesting and quite special. And then briefly the arterial network. And then a bit more about filtration and that formula, the K filtration coefficient multiplied by the balance of the hydrostatic pressures in the in the capillary versus the Bowman's capsule. Take away the sigma reflection coefficient, again, through the balance of the oncotic pressure in the capillary minus the oncotic pressure in Bowman's capsule. And then finally, the juxtaglomerular apparatus, or the JGA, and the three different cells, the macular denser cells, mesangial cells, and the granular cells that are involved there. And yeah, we'll definitely go into the hormones and each hormone in the next few sections. So really well done, great summary, Archit. Thanks very much for watching and listening, guys. We'll see you again next time.
Thanks, everyone. Bye.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.